Thanks again, everybody, for joining us today. My name is Kevin Ripplinger, and I'm the database navigator for the DaCCoTA. I'd like to welcome you to the Understanding Community Health Centers and Opportunities for Research and Data Partnerships presentation. Our distinguished speakers for today are Shannon Bacon and Becky Wahl. Shannon is co-director of the Community Engagement and Outreach Core with the DaCCoTA and serves as the Senior Health Equity and Partnerships Manager at CHAD. She holds a Master of Social Work with a concentration in Communities and Social Systems from the University of Michigan and is dedicated to supporting health centers and addressing the social drivers of health and building partnerships to promote health equity. Becky is the Director of Innovation and Health Informatics for CHAD, leading the Great Plains Health Data Network to support health center members through collaboration and shared resources, expertise, and data to improve clinical, financial, and operational performance. Earning a Master of Public Health with a concentration in Public Health Informatics from the University of Illinois at Chicago, Becky will provide her insights and expertise throughout this presentation. So thank you again for joining us. And at this time, I'll turn the presentation over to Shannon.
Thank you so much, Kent. I think Becky's going to pull up our slides, and it's good to be here and see some familiar names and some new names. We always say we never want community health centers to be the best kept secret. And so any opportunity to share about their great work and some opportunities for partnership with CHAD is exciting to us. The slides are just coming. So we wanted to kick off just kind of with a level set and share a little bit about what community health centers are. And so you can go to that slide, Becky. So some of you may be familiar, you may have heard them called federally qualified health centers. We tend to just use the term health center to sort of encompass both. Federal is a federal designation, essentially. But if you're not familiar, community health centers are nonprofit, community-driven clinics. They've been around for over 50 years. They actually, just a kind of fun history note, they grew out of the civil rights movement. And so the first two health centers started out in 1965. And it looks like it's showing your notes view, Becky.
All right.
That always happens to me too on my computer. The first two started out in 1965, and it was really the culmination of activists who recognized that we couldn't achieve racial equity without equity and access to healthcare. And so I'm just going to do a short history lesson. I know this wasn't in our slides, Becky, but one of the physician activists, Jack Geiger, had observed a community-based model where the community is really identifying health needs and helping shape priorities, and where there's really this kind of whole person care approach. And he had observed that in South Africa and ended up working with a lot of other physician activists to write proposals to the federal government. And so here we are today with over 1,400 health centers across the country. So it's really just kind of a neat story how that evolved. But today, health centers provide high quality primary and preventive care to all individuals, regardless of insurance status or ability to pay. So they'll see everyone. They accept commercial insurance. We'll kind of talk about their payer mix. But they also are able to offer a sliding scale fee. And so they do see a significant number of uninsured folks as well. And they're located in what we call health professional shortage areas. So these are areas typically in underserved, low income, urban and rural areas. And so in a rural and frontier area, the health center might mean that there can be access to healthcare in a place that really doesn't have the volume to sustain a typical clinic. And so it brings access in that way. And then in urban areas, they're often strategically located in more underserved areas of that community. And then patients receive services that promote health, diagnose and treat disease, manage chronic conditions and disabilities. So there's a list here of kind of the range of services provided. And this is really key to who health centers are, that there's this integrated approach to care. And so they provide primary care and they think about that in a very holistic and integrated way. And so there's the medical aspect of primary care, right? But then many health centers also have dental, behavioral health integrated in under one roof. And then you see things like insurance enrollment specialists. My screen is hiding. I think that's vision. Yeah, some places have vision care, transportation, interpretation, and pharmacy. Some of their federal requirements are that they really have to work to eliminate barriers to accessing care. So if someone has, say, a transportation barrier, they're going to try really hard to overcome that with the patient and get them connected to resources so that they're able to access care. Same thing with translation and interpretation. Some of the health centers in our region that have a larger immigrant, foreign-born New American population actually house interpreters as part of their staff that are there on site, can attend appointments with folks. And then some, if they don't have as large of a population best served in a language other than English, they may utilize something like a language line. So just to give you a sense of like the really broad scope of health centers, and then we can go to the next slide. And then who is CHAD? So who are we kind of in relation to these community health centers? So we are a federally funded primary care association. And there's a primary care association in every state across the country. We happen to serve as the PCA for both North Dakota and South Dakota, just with our state's kind of lower population. And so our board of directors is made up of the leadership of community health centers. So we work together really closely. They really help drive what we do and vice versa. And then CHAD supports health centers really in their mission to provide access to healthcare for all Dakotans, like I said, regardless of insurance status or ability to pay. So some of the ways we do that, we're a training organization. So we provide a lot of various trainings to health centers. We facilitate a lot of peer networking. So there's a lot of value in bringing together staff across the region at health centers who do similar work. So for instance, in South Dakota, many of the health centers are implementing community health worker programs. And so we'll convene them together or share best practices, surface training and technical assistance needs that they might have. We have a clinical quality network team, a finance network team, lots of different network teams that we bring together. And then we also will sometimes facilitate more of a coordinated implementation of an initiative. So one example, there's lots of examples of this, but one would be social determinants of health screening, that if we know health centers, this is something they're interested in doing, that we work together collectively and learn together across the network about how to do that really well, and then provide a lot of coaching and technical assistance. Next slide. And then Becky is going to talk more about what we call the Great Plains Health Data Network. So I mentioned that CHAD as a primary care association serves North Dakota, South Dakota. We have a whole other arm of our work as part of CHAD that Becky really leads through the Great Plains Data Network that also includes Wyoming. And so this is a sense of the patients served through that network. So these statistics pull together North Dakota, South Dakota, and Wyoming health centers that participate in our data network. So you can just see kind of a snippet here. This is showing you patients by race. And so you can see that about a little over 30% of patients at health centers across those 3 states were people of color in 2021. This shows some of that racial breakdown on the left, and so you can see about 10% were American Indian. You can go to the next slide. And then this just shows you kind of a glance at the payer mix. So you can see around 30% uninsured, around 30% Medicaid, and then the remainder are Medicare and private pay. And then you can see the total number of patients within the Great Plains Health Data Network across the 3 states. And in total, that's about 104,000 in the most recent year. So with that, I am going to kick it over to Becky, who does a great job leading the Great Plains Health Data Network. She's led the development, and she's going to share more about what that is.
Thanks, Shannon. So the Great Plains Health Data Network was established in 2019. We are an affiliate of CHAD, essentially like under the CHAD umbrella as a service line that is provided. In order to be a HCCN, and a health center controlled network is the federal entity that we are. It's, you know, grant funded with HRSA. And we call ourselves the Great Plains Health Data Network. But in order to be an HCCN, you have to have 11 health centers as part of the network. And we did not have enough in North and South Dakota, and we work a lot with Wyoming, which is very similar in geography, in size, very frontier, rural environment, that it worked very well to partner with the Wyoming Primary Care Association to go together on this HCCN grant and develop the Great Plains Health Data Network. So through this partnership, we have 11 community health centers that are part of that network. We have 4 health centers in North Dakota, 3 in South Dakota, and 4 in Wyoming. It's kind of a Venn diagram, right? Like you have some that are part of the PCA, some of it part of the Great Plains Health Data Network, and some that are not, right? So there's, you know, kind of 3 parts of the mixtures, the matching of the health centers within, across the PCA and the GP11. In Great Plains Health Data Network, it's a mouthful. So because we have 11 members, we often call it the GP11. HCCN, GP11, Great Plains Health Data Network, all of the same entity. So we cover a large mass. Like I said, we cover a little over 246,000 miles with 2.2 million residents across all 3 states. We have 76 sites that, you know, we have 11 members, but they have multiple sites. So we have 76 clinic sites across the 3 states as well. And we have a very broad range. Some of our smaller health centers are homeless clinics. And so they serve, you know, up to 362 patients every year. And some of our largest one is up to 28,000 patients served. So across the entire network, we have about 105,000 patients that are served within the network. So this is just a map explaining, you know, down here you can see, here's the 4 health centers that are part of North Dakota, but you can see the, you know, broad coverage that they have in, you know, services provided. So here's all of those sites that I had mentioned. In North Dakota, here is South Dakota, and then Wyoming's a little bit smaller. We don't have one of their larger health centers in Wyoming. They are part of another HCCN, and you can only be in one HCCN. So we do have some of the smaller health centers in Wyoming as well. And then this just shows a graphic of who all of our health centers are. If you go to our website, you can click into each one of these health centers and get a little bit more background on each one of the health centers part of the Great Plains Health Data Network. So we established this network. We do great work with the PCA, but a lot of times we were running into the barrier of we can't do this because we don't have the data, or we can't do this because of, you know, we don't have the health information technology resources or staff to advance this work. And so we just felt like this would complement the work that was being accomplished at the PCA. So some of the focus areas that are included under the Great Plains Health Data Network is data security. We want to make sure that our health centers are keeping the data secure, you know, making sure their networks are secure, their EHR is secure, you know, free from cybersecurity attacks, et cetera. So that is a huge part of having data. So we help to ensure that they are meeting the requirements there. And then we did a lot of work regarding data strategy. So our health centers, you know, there's a range. Some of our health centers have so much data, they don't know what to do with it. And some of them don't have enough data or don't necessarily trust it. And so when we decided to implement this population health management tool, we wanted to take a step back and say, what are each one of our health centers' data priorities, and where is the data coming from? What are your data sources? Just to pull those priorities to the top and not just collect data just to collect data, right? So really just prioritizing and giving data a structure, getting them to think about goals and baseline goals, benchmarks, and really using data to make decisions, data-driven decisions in their organizations. And then virtual care is another focus. So we really are this year working on, they all can do telehealth from the medical and behavioral health standpoint, but really like after the public health emergency, what can telehealth look like across the network? So we're really working on expanding and utilizing telehealth across each one, in the network across different service lines, and really expanding and providing some support along the telehealth. And then part of that is patient engagement, right? So having our patients, being in communication with them, allowing them to do online scheduling via their mobile phone, being able to two-way text with their providers and their care teams, and then doing online registration, like their social risk factor screenings. They can, instead of waiting in line at the front desk, right, like giving them the resources on their mobile phone or through their portal, whatever that might look like, to be able to do that online and save time. And you can imagine some of the patients who don't have transportation, if they can fill in their paperwork online and do telehealth, they don't even need to leave their home, right? So it's just meeting patients with where they're at, and helping them from a technology standpoint. And then the major initiative that I will talk about today, as a network, we wanted to look at implementing a population health management tool. So the tool is the resource that we use to layer on additional data. So it's a bigger, broader term. We wanted to develop a data aggregation and analytics system where we can bring in the data from the health centers. Each of our health centers have different electronic health records. So across our 11 members, we have 6 different electronic health records. So you can imagine when we are doing network work, it is difficult to gather that data. And so what we did, we went through an RFP process and we chose Azara as our population health management tool. And that allows us to take different data elements, and I'll speak to that later on in the presentation, and layer that data on, pulling directly from the data that is being collected in the EHRs at the health centers. And so we are in the process of implementing that and working towards sustainability for that tool. So just a little bit more about the DAWs, and you'll hear us talking, primarily about the DAWs. You'll hear Azara, population health management tool. It's all, the same thing. I think DAWs is just a broader term explaining like it's not just the EHR data that we can collect. There's additional data elements that can be layered in. So like I just explained, that the Azara is a population health management tool that we can aggregate the data and make it come into, it can be pulled from different questions in their EHR and aggregated into a similar place in Azara, right? So we can look at it and say, you might be asking this question differently related to social risk factors, and they are asking it differently, but when they pull into the network, we can see it in one spot, if that kind of, explains it a little bit further. So we can look at it at a network level, and each one of our health centers can also look at it at an individual level and analyze their own individual data related to their patients and use it at point of care. I talked about that it goes into their electronic health record. So as long as our health centers are collecting the data, we can pull that data into Azara. So we currently have 4 health centers connected and 3 near completion of implementation. And we are anticipating that the remaining 4 health centers will be implemented within the next 3 to 6 months. We have had significant improvement in the last 3 months of progress made. It can be up to a 3 to 4 month implementation. We've had some health centers that are stuck on data validation. We really talk to that and speak to that. Like, we need to make sure the data that you're pulling in is accurate, right? Garbage in, garbage out. And so we do, you know, some of our health centers have spent some significant time, like a year, on implementing. And so it just depends on how that data is coming over and what that data is looking like. But it can be a lengthy process. But I do feel like some of the ones that took longer have made progress in the last couple months. And the ones who were late to implement have also made progress. So here's the data that is available in Azara. Our health centers are required to collect UDS data. And so it is different data based on patient characteristics, different services provided at the health centers. There's different clinical processes and health outcomes that are collected, patients' use of services, like we can pull the, you know, how many telehealth visits they've had, or what is their enabling visits they've had, how many times have they used an interpreter, et cetera, right? Pulls staff data, their costs and revenues for each one of the health centers. And so that gets submitted to HRSA, and then they have the UDS mapper. If you haven't, as a researcher, if you haven't heard of that, that is another resource at the national level as well. All of that data gets pulled in. Our health centers are UDS crunch time right now. It is due on February 15th. So they will be getting that all submitted, and we will be, you know, we're able to pull that data into Azara. So that data is readily available. It updates every single night, and we have that in Azara. And then in addition to that, some of the social risk factor data is included in UDS, but we can add so much more. Like, many of our health centers implement Prepare, which is a standard template, you know, at a national level, recognized tried and true tool that many of our health centers across the nation use to collect social risk factor data. So if they are collecting that, that gets pulled into Azara, and then that data is used to risk stratify the patient. So each of the patients get scores based on whether they're high, low, medium risk, and it, you know, data related to their diagnosis is contributing to that. Data regarding their utilization of ER and hospital visits, their social risk factor data, all of that contributes into that risk stratification for those patients. And then here's just a laundry list of the clinical data that is in Azara as well, and at our health centers that is part of UDS. This is, you know, our health centers can definitely be doing above and beyond this, right? I'm not saying like this is the only data they can collect, but this is what they have to collect, right? So that data is available as well. I'm just looking here. Oh, Shannon just shared Prepare. Thank you, Shannon. So I'll turn it over to Shannon, and she can talk a little bit about different research ideas that we could be utilizing Azara data for.
Yeah, thanks, Becky. And these are just examples. And so, you know, I think Becky kind of touched on this, that the data belongs to the health centers. And even though Chad has access to it, the first step would be a conversation, right? So if you have a particular research area of interest and you're trying to kind of understand, is there an opportunity here to potentially access health center data as part of your analysis, or even test an intervention with health center patients in partnership with a health center, the first step would just reach out to Becky and I, and we're pretty much open books. Like, we're always happy to just meet up and visit. We love hearing about different research areas. It's always interesting to us. So that would be the first step. So this definitely isn't an exhaustive list, but these are just some thoughts I put together to give you an idea of some of the capabilities. So Becky mentioned the patient engagement tools that many health centers are utilizing. So one of the capabilities that those will have is two-way text messaging. And so, just as an example, that would be an opportunity to test effectiveness potentially of tailored messaging, either around reminder and recall notifications related to different screenings, or disease management education. So you could take a certain cohort of patients with a certain diagnosis, and test out, patient education or sort of calls to action, and see if that has an impact on clinical quality measures or health outcomes, social determinants of health. So I put some clinical quality examples. Tobacco cessation, I know that there's a NIH-funded research program in Utah that did collaborate with community health centers and the primary care association there. And they did some direct-to-patient text messaging around tobacco cessation, and they actually were able to prove significant improvements. And so that's just one example. Something similar could be done related to cancer screenings, hypertension, diabetes management, immunization, depression, other things as well. But like Becky said, these are things we know the health centers have data on. It's sort of their bare minimum. As kind of a social determinants of health example, I just kind of threw this out there. You could test out text messages with transportation assistance offers pre-visit for a diabetic cohort of patients who've screened positive for transportation needs previously, and see what's the effect on diabetic management from that intervention. So just examples. I have a couple more, and these are really meant to just kind of trigger in your mind something that might relate to your area of research that could be relevant. So another one could be analyzing the social determinant of health data that health centers have and looking for correlations to clinical quality measures, and then identifying and testing potential interventions. So as an example, what is the top social need for patients with uncontrolled blood pressure? Testing out an intervention on that social need, and seeing whether you see an improvement in blood pressure with that. The last one, we actually have quite a few health centers that are beginning to co-locate some sort of food pantry or food bag option in partnership with a food bank at their clinic. And so they would screen a patient for food insecurity. When that patient screens positive, they'd be offered food right there on site, but then also be counseled about kind of more long-term resources, getting connected with SNAP or WIC, things like that. And I think one of the things that we're interested in is what are the implementation factors in that sort of intervention that really contribute to success? And also, what are the health outcome impacts of that intervention? So those are just a few examples, and hopefully that triggers some ideas for you. But like I said, the first step is just reach out and visit with us, and we're always happy to explore potential. I'll turn it back to Becky.
Okay. So just based off of Shannon's recommendations, or like ideas, right? Not recommendations, ideas of what could be done with a research project. I just wanted to show you like what that visual will look like or could look like, or the ability of what our health centers and what we would see related to that, potential research project, just to get you an idea of the data that we have available. This is from our test system. So if you start looking at the numbers, they're not going to make sense because it's all from our data or from our test system. So we run it in different ways and it's just dummy data. So just the tobacco screening, what you can see here is that like we can go in and look at the number of patients who have not been screened, right? And look in who is a tobacco user and hasn't either they've received it or cessation advice, right? Like recommendations, or they have they're still continuing to smoke, right? And then what you can do is actually drill into that and get a list of patients, right? So here's the number of patients who haven't had a screening. And what our health centers can do is we can get a wide number of here are the patients available, and then here is the patients that we can actually take action on, right? So you know, let's say you came and said, we want to look at all patients who haven't been, you know, have been screened and haven't received, you know, cessation recommendations, right? Then we can pull of who all of those patients are based on what areas of focus you want to have within the states. And then we can actually drill down and see who those patients are and do interventions. For example, like maybe we text them, right? Like here's some, you know, services for tobacco cessation, right? So you really can take a broad number and hone in on that at the patient level. And then diabetes and transportation. So this is a list of patients who have a diabetes diagnosis and who have, you can see here that I can pull those SDOH needs, you know, identified with those patients, and you can see that they have a transportation need, right? So you can also see that when their next appointments are, so you can actually sort this and say, this patient has diabetes, has an issue with transportation, and you can do outreach, right, to that patient to see if they need assistance with transportation for their upcoming appointment, right? So it just allows you to take the data that we have and slice it and dice it to meet your need. And then again, you can do outreach. Do you need this transportation? Or maybe that's like, hey, maybe if you don't have transportation and you can't come in, you know, your kids are at home, example, like, then maybe we do a telehealth visit, right? But then it keeps those contacts with the provider, and it just provides more of a targeted outreach for those patients. Then this one is, one of the great abilities is to be able to take our, you know, clinical data and slice it and dice it with the social risk factor data, which is very rich. A lot of people don't have access to that data. We're still working on validating that, pulling that data in. But our health center, Shannon, has done a ton of work with our health centers to work on trying to do, you know, universal screenings for social risk factors. So you can take your hypertension patients and like this pulls all of the hypertension patients who have social needs that have been assessed through a standardized screening tool. And you can see that for those patients with hypertension, which is 88%, and they have, and that have had the social needs assessed, the higher social needs identified here in this test data is education, utilities, and food, and food insecurity. So those are some of the highest needs that you can see here, right, for your hypertension patients. Utilities, food, and education. You guys probably can all see it. I'm like trying to find it on here to point it out.
It's in the lower
Thank you.
right
Here,
middle. Yeah.
right here. I was like looking for education EDU. So you can see like your hypertension patients, here's their social risk factor needs. You know, like the highest social needs for those patients, right? So then knowing that food insecurity is the primary need for hypertension, again, this is dummy data, you can pull up a report of those patients with hypertension with the food insecurity identified here, and you can develop a cohort of patients that you can manage. So you can create this list and make this list. Let's say we do research project hypertension and food insecurity, right? So then we can manage these patients and we can do outreach to them on making sure if you have a food insecurity, how can we eliminate that food insecurity? How can we provide you the appropriate foods to lower your blood pressure? And then you can set clinical targets. Here's where this group of patients is right now. This is how they are coming up on their hypertension measure, but here's our target as part of a research project, and we can manage them and, you know, do through care coordination, whatever that might be, to improve to get us to that target, right? So it allows you really to look broadly and really target in on those patients. And then here just showing, like, in addition to the social risk factor clinical data, we also have demographic data that is collected through social risk factor data. So you can come in and see what the race, ethnicity are of the patients related to a clinical measure. So pretty basic information here, but we do have the ability to do that. And this is just some examples, right? Like there's so much more we can do.
Can I add one thing, Becky?
Of course, yes.
I didn't say that in the research examples, but that would be another element of like culturally appropriate outreach and messaging and interventions. And so knowing that we do have that ability to look by various demographics at clinical outcomes and, you know, always looking for ways that we can be more culturally tailored and appropriate. So I think that's another, you know, potential research collaboration if it aligns with someone's area of interest.
So right now, like I said, we have basic data, not basic, it's pretty robust data coming in from the electronic health records, right, into our DAWs. But eventually we want to add in admission, discharge, transfer data. That is critical information when a patient goes into the ER or the hospital. You know, having appropriate follow-up when they come out of the hospital is critical for patient outcomes, right? So we are working with our health information exchanges in each of the states to pull that ADT information in, so our health centers can go in and say, here's the patients who've had a discharge and they need to be contacted to make sure that their discharge, you know, instructions are being followed up on, or do they need to come in for a follow-up visit, right? And so it's just micromanaging those populations when they need it most. Claims data is also, you know, we're working with our Medicaid departments in addition to different payers to get claims data in because we know what we know, like whatever is in the HIE, we know what our patients are telling us, but there's other things that we may not know, right? And so the claims from the payers can actually kind of complete that data. The more robust and comprehensive the data, the better picture you're going to get up for that patient. Referral data, yeah, so we don't have any, I wasn't sure if I had closed loop referrals, but there's opportunities for, you know, if we make a referral out for a patient, has that referral been, you know, completed? Have they actually went to, you know, the specialist that they needed to? Is that information coming back in? We made a referral to the food bank. Did that actually get done, right? So closing the loop on some of those referrals. We're very basic right now on that, but there is opportunity to expand that in the future. Patient engagement data, we are currently working on implementing the patient engagement tools at the health center, but then the texting, right? Like how is that information going to come back into the HIE or the EHRs, and how can that information be added in as well? HIE data I talked about with the ADTs. Prescription fill data is another option that we can have. These are all add-ons, so these are additional costs, and so we're trying to get just the minimum system. You know, some of our health centers have different add-ons implemented already, but we're just trying to get the basics, but these are all of the what could be available, right? And same thing, like Shannon said, here's some ideas that we have, but you guys might be thinking of something that we may pitch to the health centers and they're like, we're very interested in this. We want to begin collecting this data, and how can we add this data in, right? So we're just giving you some ideas of what is possible for now. So how to request the data? Where do we go from here, right? So if there's something that you guys are looking at and you would be interested in exploring further with our members, reach out to either one of us and begin to have some of those conversations. And so it would be, where do you want to focus, right? Like you can see our maps. Is there a specific, is it North Dakota? Is it South Dakota? Is it, you know, on the Western side? Like identifying where you really want to focus. Is it all 3 states, right? All 3 of our states will be, all 11 health centers are planning to implement this tool. And so it's just narrowing in the focus of where you want to really focus your research on. And then what data is needed. I think that is the next step. Like, what is the data that you need to make sure that your research project is, you know, as robust as you need it. just let us know what that data is and we can talk through it. Is it available? Is it something the health centers want? And then once we have some of this basic information, we'll go back to our health centers. We cannot share any of this data unless our health centers are on board. So that is the biggest thing, right? We have this data available, but they have to approve it. They have to be on board with wanting to participate in this study. And I would say, like, ever since we've started this partnership, we have really seen interest in the research work compared to what we were, 3 years ago before we had this data system. And so Shannon has done amazing work with that as well. And so it really is something our health centers really have been open to. And there's, different providers and staff who are interested in doing some of this work. And so, and hopefully, Kent, I'm not speaking out of term here, but we have seen in the past that other researchers have included this in their research project for funding for a data use agreement into their NIH grants, for example, right? Like they apply for these grants and they have, it's essentially a data use fee. Then what happens is that gets put back into the expenses for our health centers to manage this tool. As you can imagine, technology is very expensive. So each one of our health centers pays $18,000 to $35,000, depending on the size of their health center, annually for this system. And that's bare bones, right? And so you can see health centers don't have, we are very resourceful, right? So we are open to partnerships. Like, yes, this would be great for our patient. We're open to research, and we can help to, sustain our Azara tool. That is a win-win for everybody, right? So, that is something we can work out the details of what that looks like. There's additional add-ons. Let's say the data isn't there and they need to map new data, there might be additional expenses. And so we could work through that once we have like the data defined of what you need. And then we would do data use agreements between the health center, between you, between us, and start working on that project. We, have begun to have some discussions, but like I said, we're, new to this as well. So it'll be a learn as we go type of project, but we're very excited about it. So any questions?
Gosh, I had a thought, Becky, and now I was responding in the chat. Oh, I was just going to share like the dollar figure that Becky shared on her screen would be like the total amount that a health center is probably investing annually, at least a bare minimum. And so the data use agreement that we would set up with a researcher would be scaled down to the type of data you need. So we would look at, what would be the staff time involved in pulling that data. And so that would be a lower amount than what was shown more than likely, but that's something we could talk through. And it would take us some time to just, like you said, Becky, understand what your data needs are, and then look at what the process would be for us in pulling that. Is it data we already have? Is it a new collection? And then we could visit about that. And I did get feedback from the DaCCoTA admin core that is something that grantees can budget in for, a data use agreement with CHAD, if there's specific data that we can help you with. And then, like Becky said, the next step would be for us to ask the health centers, because it's their data, but that we can facilitate that process. And then one other thing I thought of as you were sharing was just, we gave some examples for specific research projects, but we're also open to seeing, if you have a project already in mind, but you're needing to do like a survey, you're needing to get some sort of patient feedback, we're always happy to approach a health center and ask, is it something they're willing to promote? Could they use their text messaging to send out a link to interested patients? I know we had one of the research projects through the COBRI at UND that Spectra Health just hung up a flyer for, and they were actually pretty excited about it. So just know that that's kind of maybe a lower hanging fruit piece too, is reach out with studies where you're looking for enrollment if you think a health center would be a good partner in that, and we can always explore that. And then I saw Bridget Diamond Welch on, and it made me think about workforce. So Hi, Dr. Diamond Welch. And so I wanted to highlight too, like we focused a little more on the clinical data today, but health centers also have data on things like provider productivity, cost of care, and there could be a lot of value in support around analyzing some of that more administration level of healthcare organizations. Becky, I don't know if you want to add anything to that, but that was one thought that I had.
Yeah, and they do have finance operations module of Azara. None of our health centers have implemented that, but that's an example of, and Shannon is totally right. Like I gave you kind of an estimate of what their investment is into this, but that is like, we would have to definitely break that down and determine the needs. But that's an example of if that is something that you are interested in doing, they don't currently have that financial operations module added, but we could add that with additional funding. Does that make sense? So that's a good example of what is the data you need and what would that cost be for that data. And partnership, I think it's just the support of having your, providers and health centers, supporting the work that you're doing, admin, time and resources as well.
There were a couple questions. One was, do we need IRB protocol? My first response to this would be, my guess would be yes. Mostly because we've had to have IRB protocol for other secondary sources of data or electronic health record data. So I will verify that. I will include that in my follow-up email to the participants today. Also, the recording of the presentation will be available on the DaCCoTA website under the BERDC core. So I'll have not only the recording, but I'll also include the slides so you can refer back to this when you would like to. Are there any other questions for anybody? Sorry.
I guess I have a question. Shannon, Becky, thank you so much for such an informative presentation. My mind is definitely swimming with all the data and different acronyms and trying to put it all together. As you know, I am interested very much in social determinants of health and looking at different ways of gathering data. And right now, we're sort of entertaining this discovery project of querying providers just in terms of how they see social determinants as being important or not in their practice, how they use it, if they use it, what they would like if they had access to more, just from a very open-ended sort of clinical interview, probably looking to do that either over email or over a short Zoom call. And just throwing that out as like, maybe you could even speak to the issue of access to providers in health clinics and how one would go about something of that nature.
Yeah, I mean, my first thought, Becky, is we'd be very interested in that. And we've put a lot of time and resources into social determinants of health work, and it aligns really well with kind of the history of the health center movement and what health centers are charged with. I think we would be interested to understand how providers think about that within health centers. And I think they would have a lot of interesting insights. So would love to visit more about that, Harry. That sounds great.
Excellent. Okay, well, I'll just follow up with you then in the near future.
Yeah, and in an example like that for others, I think we can be a communication channel. Like if you have surveys that are more provider targeted or healthcare workforce targeted, that may be something that we potentially could help disseminate. If you're doing focus groups, we may be able to work with you to pull a focus group together with health center staff. So it's, just reach out and we can always explore potential with those things.
And I think just to add on, Shannon talked about, if you remember at the beginning of the presentation, what we do is a PCA, right? Like it's not just data, but we have different networking teams, clinical workforce, we do a lot of coaching with each one of our health centers. We talk to members of the team on a monthly basis on some of the networking calls, right? Like, if there's an idea, we can bring it back. Like, if you're wanting to do research in North Dakota, or like, is this of interest? We can definitely be a communication channel to reach all of our health centers, right? So instead of you reaching out to who are the contacts, right? Like, we already have relationships and communication, methods set up with a lot of our health center members, and we're very, we have great relationships with them. So, that's another aspect of how we could support some of this work beyond just the data.
If I may ask one additional question too, I'm really curious in terms of funding, federal funding, if you could just speak a little bit to the issue of how that is funneled into CHAD and into the data network. Is it through block money, or is it you appeal through the states, or is it directly to the feds through grant?
It's fully funded through HRSA. So a federal grant. We receive funding based on how many participating health centers are in the network. And so we receive that funding, and then that gets divided up upon, personnel and operating expenses, and some of it gets, we can support Azara as well, implementing Azara, right? And being reliant on grants, that funding has been around for quite some time, right? But we always look at different partnerships of where we can work with the state or work with researchers on, those grant funds get used up very quickly, right? And if you're always just putting it to the same thing, right, that limits some of the work that you can do. And so it is a 3-year grant that we competitively we apply for every 3 years. So we just received funding for the next 3 years. So we are fully funded until 2025, and then we'll continue to go. This has happened for many years. We actually were one of the last HCCNs in the nation to get funding. So it's been quite some time. The funding has been around for quite some time.
So you kind of answered one of my questions too, in terms of like, you would be eligible then to, let's say, apply for a university community partnership grants for NIH grants and such. That would
Yes. So we have our main grant, our operating grant, right? And there are some additional contractual, budgets that we have to, for example, Azara, but that also positions us well to apply for other networking grants. Collectively, where we gather our members, say, are you interested in pursuing this, and applying for a different grant? And we are open to that as well, to continue to add on different work that we can do and resources. So yes, we have that structure already built from a network perspective.
Are there
That's
any
a good partnership, because we're weak on the NIH side, the research side, right? So that's why it's a great partnership, because we do have grant management, but research is a different skill set for us.
Are there any other questions from anybody?
No, I just wanted to thank you for this presentation. It's really useful to start thinking along these lines, and I actually want to rewatch it, and then I might have some more questions. I have a lot of faculty I'd like to share this with. So if it's okay with you, Shannon and Becky, I might be reaching out just for some follow-up information so I can provide them with the overall what you're offering here, because I can already think of grants that I would like to pursue on my, just for myself. So I appreciate this, and I will definitely be following up.
Yeah, absolutely. That sounds great. And we're also always happy to, if you have a group of faculty from USD,
Yes.
Bridget, who want to we're happy to redo this whole presentation and tailor it to your team. Like, we're open, so just reach out.
That's a great idea. Thank you.
Training and technical assistance, it's what we do all day. So it's just we can pretty much adapt and tweak things and do other trainings anywhere we need to.
Well, I'd like to thank Shannon and Becky as well. Tremendous resource. Thanks again, and thanks again to everybody for joining us today.
And thanks for letting us present today. We appreciate it as well.
Thanks, Kent. Have a good day.
All right, bye-bye, everybody.
Bye-bye.